Can you guys hear me?
Hey, Hafsa.
Good afternoon, everyone. I'm Hafsa, for those of you that I haven't met. I'm one of the pulmonary and critical care first-year fellows, and I'm going to be talking about chronic cough, the evaluation and management in the outpatient setting. When I first started doing this presentation, I thought it was going to be more of a general topic, but the more I read, I felt like it was actually one of the more challenging symptoms that we deal with in the outpatient setting, and hopefully by the end of the presentation, we'll all potentially be a little bit more comfortable dealing with this symptom. So I don't have any disclosures, and I'm gonna start by discussing a case. So this was a 71-year-old male with a past medical history significant for glottic squamous cell carcinoma status post multiple excisions, and radiation therapy, was in remission since 2017 and was following up with ENT. His ENT physician had referred him to the pulmonary clinic for evaluation of chronic cough as well as abnormal imaging findings. So a little bit more about the history. The patient reported somewhat a history of like maybe 6 weeks of dry cough that was worse at night, waking him up from sleep. There wasn't any associated hemoptysis or phlegm production, no shortness of breath, no chest pain. He did report some weight loss, but it was intentional weight loss. And his functional status was completely normal, continued to, go by his day, played golf almost every week. In taking more history from him, he didn't have any symptoms to suggest postnasal drip, rhinitis, or sinusitis. He didn't have any heartburn or acid reflux symptoms, no dysphagia or aspiration events, and really his entire review of system was unremarkable. He did report a history of prior smoking, a 30-pack year history, and quit in 2010. And at the time that we saw him, he was not on any immunosuppressive therapy. He was referred to us somewhere in June 2020. His physical exam was largely unremarkable. So you see this patient in clinic. Obviously, the patient's being referred to the pulmonary clinic, so he's going to get PFTs. His PFTs showed only some mild obstruction, and the DLCO was normal. He brought in his CT scan reports from an outside hospital, and it showed centrilobular paraseptal emphysema. And in looking through his charts, he did have direct laryngoscopy with ENT that showed vocal cord changes related to chronic untreated acid reflux. So at that time, his cough was thought to be, multifactorial in nature, probably related to prolonged untreated acid reflux. So someone who's had multiple procedures done, laryngeal procedures done, someone who's had radiation therapy for a prior glottic cancer. So maybe, silent aspiration. A barium swallow was ordered, potentially maybe even referred to the patient to GI. He was diagnosed with COPD. He was at risk for lung cancer, so he's referred to the screening program. And in terms of his glottic cancer, he was following up with ENT. So on follow-up, his barium swallow was positive for oral dysphagia and silent aspiration. He was started on treatment for irritable larynx syndrome with gabapentin by the ENT physician that had been following him up. He didn't really see the pulmonary clinic or get in touch with any of the pulmonologists afterwards, and he reported that his symptoms didn't really improve, and he had to go to urgent care multiple times because he was developing worsening cough and new shortness of breath. So around 3 months after his clinic visit, he presented to the hospital and was admitted. Now he had worsening cough with sputum production, and he was also hypoxic. As you can see, his chest X-ray showed a right basilar opacity suggestive of potentially a pneumonia. He did eventually undergo a CT abdomen, pelvis, as well as chest, and this is the significant finding. So he has a fungal tracheal mass. This is another cut of the same tracheal mass. He also had a right hilar lymph node, subcarinal lymph node. And the final read on the CT scan was patchy bilateral airspace opacities. Maybe he had pneumonia at that time, fungating tracheal mass, enlarged mediastinal right hilar lymph nodes, multiple subpleural lung nodules, and ill-defined metastatic liver lesions. He was admitted. He had rigid bronchoscopy, which found a large endobronchial polypoid tumor causing around 90% obstruction at the level of the mid-trachea. He underwent debridement, debulking, and Y stent placement. Pathology from the tumor came out as poorly differentiated carcinoma. Eventually, he was discharged in somewhat of a stable clinical, somewhat of a clinical picture. And he had close follow-up with IP, oncology, and ENT, but he couldn't really keep any of his follow-up and was readmitted within 10 days with new onset jaundice. He was diagnosed with acute liver failure and ultimately enrolled in hospice and was discharged home. So, I mean, this is a case of a more, drastic diagnosis associated with cough, new malignancy, a new airway lesion causing really only cough at the time of presentation. But we'll talk about other etiologies. So the outline for this presentation, we're gonna go over the definition of cough and different epidemiology, the etiology, diagnostic approach, role of bronchoscopy. We'll touch base on chronic idiopathic cough and the management options, and then a summary of the presentation. So the definition of chronic cough really depends on the duration, and I think it's really important to define the duration of cough because this will guide your assessment and the different workup that you would obtain. Acute cough is usually less than 3 weeks. I think we rarely see acute cough in the pulmonary clinic. It's mostly managed by primary care internal medicine. Subacute cough is cough between 3 to 8 weeks, and then chronic cough is more than 8 weeks, which subacute chronic cough is what we usually see in our clinic. So in talking about epidemiology, like how important is chronic cough? In terms of to the patient, it's pretty important. I'm sure we've all had like viral URIs where we were coughing hundreds and thousands of times a day. And imagine a patient with chronic cough, this is their life. They cough hundreds and thousands of times a day, every day. They don't get enough sleep. It interferes maybe with a lot of their activities. It interferes with, their speech. So it's pretty debilitating both physically and psychologically for patients. In terms of, the medical epidemiological side of it and the medical burden and economical burden of cough, it's responsible for more than 30 million clinician visits annually and accounts for 40% of the outpatient pulmonary practice. So it's pretty significant for the pulmonologist. Again, defining the duration is essential because it is going to dictate the possible causes and your workup. Up to 12% of the general population reports having chronic cough or cough for more than 8 weeks at some point in their life. And in some reports, it is the most common cause or the most common symptom for which patients seek medical attention. And usually patients with chronic cough, they go to see different doctors. They might see their PCP, they might be referred to us, they might see an ENT, GI, neurology. They might see multiple different specialties and multiple different doctors. And if we don't find a successful, rapid solution for their cough, they can end up posing a pretty big diagnostic challenge. Chronic cough is also thought to be more common in females, usually in the 5th to 6th decade. And we're going to talk about why it's more common in females. So I think this is one of the more important slides in the presentation, and it really understanding the cough reflex arc or the physiology and the anatomy behind cough is important because it also helps you understand the different causes. You have these receptors these receptors can be both mechanical and chemical receptors. And they are present not only in the upper and the lower respiratory tract, but they're also present in the pericardium, in the stomach, in the esophagus, in the diaphragm, And that's why, you have different non-pulmonary pathology that can present with cough. Like we said, the receptors are both chemical and mechanical. Chemical receptors are usually stimulated by things like cold exposure, smoke inhalation, dusts, fumes, capsaicin-like products, and then mechanical receptors are usually stimulated by mechanical displacement, whether it be from a compression from a lesion, or even mechanical stimulation through like procedures and bronchoscopies and stuff like that. So when these receptors get stimulated, they send afferent signals up to the cough center, and the cough center is usually in the medulla. It's important to note that this cough center is also under regulation through higher cortical centers. And it's thought to be that these cortical centers are the ones that are responsible for why the female to male differences in cough sensitivity is. It's because that these cough centers, medullary cough centers, are under direct regulation by cortical centers. After the cough center receives the afferent signals, it sends off efferent signals to the expiratory muscles to produce the act of coughing. This is just another diagram that I found on UpToDate. Again, really important to note that the cough center is under CNS cortical modulation, sends out nerve signals to spinal, motor, phrenic, and vagus nerves, which carefully orchestrate the cough. So now we're going to talk about the different etiologies, and we're going to talk maybe in a series of the most common to the least common. So just a little bit of an overview of the different etiologies of cough. You have upper airway cough syndrome or postnasal drip, gastroesophageal reflux disease or GERD, post-infectious cough, drug-related, mainly ACE inhibitors, airway diseases such as asthma, chronic bronchitis, bronchiectasis, non-asthmatic eosinophilic bronchitis, neoplastic disorders, foreign body inhalation, and then lung parenchymal diseases such as ILD, pulmonary abscesses, and then you have some of the more rare causes that we'll touch base on. And in 10 to 25% of the cases, you may never actually find a cause for the cough. So in talking about asthma, asthma is the second leading cause of chronic cough on its own. If you combine asthma, GERD, postnasal drip in a combination, that is the #1 leading cause of chronic cough. Usually it's associated with wheezing or dyspnea or atopy or any other clues to the diagnosis, but in cough variant asthma, cough could be the only symptom. Another clue to diagnosis is that it may start to occur in a patient who's never really had asthma after starting beta blocker therapy or following URI. The diagnosis is, and we're not going to really be discussing a lot about asthma here, but the diagnosis usually was spirometry or a methacholine challenge test. You can also demonstrate elevated levels of exhaled nitric oxide. And, if you suspect that asthma would be the cause for cough, demonstrating improvement with asthma therapy is diagnostic. An important thing to note that in patients who have cough variant asthma, actually giving them the inhaled corticosteroids or the inhaled medications can trigger the cough, which would lead to less delivery of the active ingredients to the airway. So in these cases, you may consider using a spacer device, or if the patient has severe enough cough, maybe even pre-treating them with oral glucocorticoids for 1 to 2 weeks to try to alleviate some of the inflammatory changes before you can fully ensure delivery of active ingredients. GERD or gastroesophageal reflux disease, it's a very common cause, up to 30 to 40% of cases of chronic cough. And, a lot of the literature is out there to try to describe the relationship between GERD and chronic cough, and it's a pretty complex relationship, but it's thought to be that, reflex or regurgitation of acid content and digestive enzymes such as pepsin into the lower esophageal sphincter will lead to activation of the chemical cough receptors, and this leads to cough generation. Another clue that GERD could be the cause of cough is that the symptoms are usually worse when the patient's lying recumbent, and that's because it's a pathology of the lower esophageal sphincter, and when the patient lies recumbent, then you're eliminating the effects of gravity, the cough gets worse. Usually the patient will also report, associated heartburn or sour taste in the mouth. Up to 40% of the patients, their only symptom for GERD is really the cough. The initial workup is always with a barium swallow. If this is not diagnostic, then you proceed with a 24-hour esophageal pH monitoring with event markers. It's important to have event markers to correlate the pH spikes in the esophageal lumen with the actual cough episodes. GERD has also been shown to worsen asthma, and all three pathologies all three disease entities, GERD, asthma, and postnasal drip, have somewhat of a complex relationship in where they all contribute to symptoms. It can be associated with esophageal dysmotility that may not respond to GERD treatment, which makes it even more challenging to treat the cough. And it's also thought to be one of the reasons of presentation, like having cough when the patient presents with OSA, because OSA in its own should not really give you cough, but OSA is associated with GERD, and GERD is the reason why the patient is coughing, and thus when you start patients on CPAP, you improve their GERD and their cough resolves. So in looking at the guidelines in terms of management of GERD, usually trials of acid suppression therapy with twice daily PPIs for 3 months. Most of the randomized control trials that have been conducted to assess whether this treatment is effective or not have actually not shown any significant improvement. But in clinical practice, we do see that patients are improving, and more often the patients who improve are the ones that have other associated symptoms with GERD, not just the cough. This is things like heartburn or regurgitation, or those patients that you can actually demonstrate that they're having excessive acid reflux on esophageal pH monitoring. In terms of surgical intervention, there's been no evidence to support the use of anti-reflux surgery with niacin fundoplication in treating chronic cough related to GERD. Only patients who have other criteria, other surgical criteria, would undergo it. Cough is not enough for them to proceed with surgery. Another somewhat of a subset of gastroesophageal reflux disease is laryngopharyngeal reflux. And this is, retrograde movement of the, gastric content, the acid and the pepsin and the digestive enzymes up all the way to the laryngopharynx, which leads to laryngeal and hypopharyngeal symptoms. In up to 35% of the patients, the only symptom is heartburn. Most patients will also have dysphonia, hoarseness, dysphagia, or just having to repeatedly clear their throats. In contrast to GERD, this is an upper esophageal sphincter problem. So usually patients report symptoms when they're upright, during exertion, things like Valsalva. This is very common in runners. Anything that increases the intrathoracic pressure enough to overcome the upper esophageal sphincter and leads to regurgitation of acid content all the way up to the hypopharynx. Direct laryngoscopy usually shows arytenoid erythema and edema and pharyngeal inflammation. But really, if you look at the literature out there, there's really no major agreement on what is considered laryngeal signs of reflux. And then there's also this hypothesis that this is all related to, instead of it being related to acid overproduction, it's really related to sensitization of the neuronal pathways and the vagal pathways. And in up to 50% of patients that have chronic cough, we can demonstrate, or you can demonstrate, that there's a temporal relationship between even physiological acid reflux and chronic cough. So, in normal patients, there's physiological reflux, and that should not produce cough. But in patients who do have chronic cough, usually this physiological reflux will lead to cough, meaning that maybe their vagal pathways and their neuronal pathways are just more sensitive. And then the treatment of that is per the treatment of GERD. Postnasal drip, usually associated with multiple forms of rhinitis, allergic, vasomotor, perineal, nasopharyngitis. Cough could be the only symptom present, but patients usually report associated sneezing, postnasal drip, or feeling the sensation of secretions dripping in the back of their throat. Exam findings could be completely normal, or you could find cobblestone appearing nasal pharyngeal mucosa and secretions in the back of the throat. Usually, if it's very apparent that the patient has postnasal drip causing their cough, then usually we start them on a course of nasal glucocorticoids and antihistamines prior to embarking on more extensive, workup. But really, we don't have that much evidence to say that this is the right approach. And whatever clinical experience we have says that most of the time these treatments are not as they're not as good as we think they are. You can also still offer patients things like antibiotics if you think that they have chronic sinusitis contributing to their cough, or refer them for surgery, but we don't really have much data to suggest that there's meaningful effects of surgery over the cough. Other potential causes, without going in great detail, some respiratory tract infections can produce prolonged coughs for more than 8 weeks. Things like mycoplasma, chlamydia, pertussis. It's mainly related to production of secretions, airway hyperresponsiveness, and inflammation. ACE therapy, I don't really think we see that much in pulmonary clinic. Usually the primary care provider will identify it as being a cause of chronic cough before referring the patients to us, but it can happen that we'll see a patient, up to 15 to 20% of patients on ACE therapy develop cough at some point. The cough can develop within a week up to 6 months after starting therapy, and it can take 4 days up to 4 weeks to completely resolve after stopping the therapy. It's more common in women and in asthmatic patients. Usually, if you restart the medication after stopping it, patients will still have cough, or they will develop the cough again. And on PFTs, you should not see any airflow obstructions. Chronic bronchitis, it's one of the most common causes of chronic cough. However, one of the less common causes of chronic cough in the pulmonary clinic. And that's because it's associated with smoking, and most smokers have their, chronic smokers cough. So they don't really seek medical attention for it. So it counts for less than 5% of the cases of chronic cough that we see. Often smokers will come and seek attention if there's a change in their baseline cough, which would indicate, either an exacerbation, infection, or neoplastic procedure. Bronchiectasis accounts for 4% of the cases. Pathophysiology behind this is prior infections, and anything that predisposes the patient to developing bronchiectasis leads to severe repeated airway inflammation, airway damage, dilation, cystic changes, poor mucus clearance, and secretion pooling. Cough is a major symptom of bronchiectasis. Sometimes it's dry, but most commonly it is productive, and a change in purulence is an indicative of an exacerbation. You would obtain a high resolution CT, obviously, if you think that the patient has bronchiectasis. Malignancy, lung cancer accounts for 2% of the cases of chronic cough, usually due to neoplasms originating in large central airways where the cough receptors are common. Can be due to pulmonary lymphangitic carcinomatosis from extrapulmonary malignancies, and it should always be considered if you have someone who has ever smoked, is a smoker, has a new cough or worsening cough, any cough that persists for more than a month after smoking cessation, or if the patient has any hemoptysis or other alarming symptoms. Non-asthmatic eosinophilic bronchitis, it accounts up to 13% of cases of chronic cough, usually presents in patients who have history of atopy, with elevated serum eosinophils and no airway hyperresponsiveness, which is the major differentiation between non-asthmatic eosinophilic bronchitis and plain old cough variant asthma. You can diagnose this by demonstrating a sputum eosinophil count of more than 3% in the absence of bronchial hyperresponsiveness on PFDs and bronchoprovocation tests. The gold standard for diagnosis is a bronchial biopsy. However, we don't usually go that route because you can potentially get the sputum tests and have a trial of inhaled corticosteroids before attempting bronchoscopy, because most patients usually respond very well. Histology, it shows airway eosinophils and basement membrane thickening in both asthma and the eosinophilic bronchitis. However, in asthma, you also have mast cell infiltration, which actually accounts for airway hyperresponsiveness, as opposed to no mast cell recruitment or infiltration in the non-asthmatic eosinophilic bronchitis. Natural history of this disorder is variable. People who have repeated episodes appear to be at risk of developing asthma and airway obstruction. This is just a slide to show the differences in the histology. So in asthma and non-asthmatic eosinophilic bronchitis, you have recruitment of eosinophils, basement membrane thickening, but then only in asthma, you have also recruitments of mast cells, which accounts for the airway hyperresponsiveness. So what about ILD? Does ILD cause cough in itself? And I think this is one of the nice articles out. It was published in Chest, and I went through this, and really clinically significant cough occurs in more than 80% of patients with ILD. And it's thought to be that the pathogenesis behind this is that the airways become more sensitive to chemical stimuli, capsaicin and substance P. And the reason for that is that the sputum, there's higher levels of sputum nerve growth factors and neurotrophic factors, which stimulates neuronal production and nerve stimulation so that the airways become essentially more responsive. However, you should never just say, oh, the patient has ILD and that's why they're coughing. All patients who have ILD and have a cough should undergo formal testing and treatment for any other potential causes, because ILD in itself shouldn't really just cause you to cough, and you shouldn't just blame it on that. In all of the literature out there, there hasn't been really any treatment trials targeting cough as an endpoint, so we're not really sure if any of the treatments, improve cough. However, some studies have suggested that maybe steroids and IPF might improve the cough severity without improving survival or quality of life. And then there's the more rare causes of cough, things like swallowing dysfunction, recurrent aspiration. You would consider this in someone who has focal neurological deficits, prior strokes, traumatic brain injuries, or someone who has had any neurological symptoms, lesions that could compress the upper airway, things like left atrial enlargement, AVMs, retrotracheal masses, tracheobronchomalacia, which is it occurs because there's loss of rigid support to the airway with inspiratory collapse leading to cough, and it's usually diagnosed on bronchoscopy, and it's more common in smokers with COPD or obstructive lung disease. There's laryngeal sensory neuropathy that's associated with laryngospasms or throat clearing. Interestingly, chronic tonsillar enlargement. I think I read that there was some study or a retrospective study of around 230 some patients who were followed up in a chronic cough clinic, and up to 3.4% of them had tonsillar enlargement, and when they underwent a tonsillectomy, their cough completely resolved. So it has been reported to be a cause. Irritation of the external auditory canal. So there's a syndrome called the ear cough syndrome, or the autorespiratory reflex, which is thought to happen because of stimulation of the oracular branches of the vagus nerve, maybe from impacted cerumen or a foreign body or whatever it is. PVCs, another like observational study showed that there up to maybe 100 and something patients who were referred for EP evaluation, some out of the 100, it was 120 patients, and chronic cough was reported. I'm not sure what the statistics here is, I forgot to include it, but chronic cough was a reported symptom that had resolved after resolution of PVC, so it could be one of the potential causes. Holmes-Ide syndrome, caused by autonomic dysfunction affecting the vagus nerve. The associated signs and symptoms would be anisarcoria, abnormal deep tendon reflexes, patchy areas of hyperhidrosis or anhidrosis. And then Tourette or somatic cough syndrome with tic disorder. Tics can also be present as if with cough. And then last but not least is idiopathic cough syndrome, which we'll talk about a little bit further. So what's your diagnostic approach to someone who has chronic cough and is being referred to you in your pulmonary clinic, and how would you go by trying to figure out what they have? So obviously history is very important to try to narrow down what the most common cause of the cough for the patient is. You'll ask a very extensive history. You'll pay attention to smoking history, any recent respiratory infections, any drugs, associated symptoms that could maybe narrow down what the potential cause is. And then make sure that the patient's not immunocompromised, because that would be a different workup. The physical exam is really important. A lot of times it's usually normal, but pay attention to clues to the potential diagnosis, things like cachexia or muscle wasting, lymphadenopathy, potential focal neurological deficits, which could explain like microaspirations. Look at the ear always and look at the pharynx. Most important initial diagnostic step is to obtain a chest x-ray. Now, in more than 90% of the cases, the cough is usually related to either postnasal drip, GERD, asthma, either alone or in combination. And this is usually in a patient who's not a smoker, not on any ACE inhibitors, has a normal chest x-ray. So then a lot of times we usually just proceed with treating any of these conditions either alone or together. However, this is a little bit of a diagram on what to do when you encounter a patient who has chronic cough. Obviously, thorough history taking and physical exam. Like we said, if you suspect any of the 3 most common causes, postnasal drip, GERD, or asthma, you can go ahead and just trial, especially if the patient doesn't have a history of smoking or alarming symptoms, you can go ahead and trial therapy first before obtaining a chest x-ray. But almost always in practice, we obtain a chest x-ray, even if it's very clear cut from the history and the physical exam, because it's a very, low exposure, low risk type of study with a potentially, relatively high diagnostic yield in these cases, that it's almost always, you would always just obtain a chest x-ray. Obviously, you'll get it if you're suspecting any pulmonary pathology, if the patient is a smoker, or any other alarming symptoms. If the patient's on an ACE inhibitor, you DC the medication and then reassess. I hope this is like clear enough, but say we proceeded and got the x-ray, if it's abnormal, then you have potentially a reason to treat, whether it's emphysema, bronchiectasis, compression from a lesion, or cardiomegaly, then you'd go down the line of further workup and treatment. However, if it is normal, then you can go back and maybe rule out other causes. Obtain PFTs, methylcholine stimulation test to rule out asthma, being a cough variant asthma, sputum eosinophilia to diagnose eosinophilic bronchitis, and then barium swallow or esophageal pH monitoring to diagnose GERD, high resolution CT if you have obtained all of these, if you've gotten the PFTs, the X-ray, sputum eosinophils, the barium and the esophageal pH monitoring, still can't find anything, then you can go ahead and proceed with further sophisticated imaging to see if there's any pathology that was missed on the X-ray, and then maybe go back and consider the more rare causes and treat accordingly. And then if all of this is negative, then you can label the patient as having idiopathic cough, or idiopathic cough syndrome, but this is only a diagnosis of exclusion after excluding the more common causes. In reality, really, in clinical practice, we don't just, get a chest x-ray and then maybe, if it's negative, then I'll get a PFT and then I'll get that. A lot of times, we set in motion multiple different tests to try to figure out what's going on with the patient as soon as possible. So what's the role of bronchoscopy? Obviously, you're going to refer the patient for bronchoscopy if you're concerned for a malignancy. If you're not able to obtain sputum for non-asthmatic eosinophilic bronchitis, you can get like a BAL to diagnose tracheobronchiomalacia. If there's any concern for foreign body inhalation. And then I included this quote from one of the New England Journal of Medicine articles that I used to prepare this presentation, and this was written by a pulmonologist in the University Hospital of South Manchester, and they'd said that among patients in whom the diagnosis remained unclear after a plain chest x-ray, PFTs with a methylcholine stim test, empirical reflex treatment, ENT evaluation, up to 10% were found to have abnormalities on bronchoscopy, although it's not clear if these abnormalities really explain the cough or not. But I felt like that was an interesting statement and wanted to mention that. So, chronic idiopathic cough. So you went through your whole algorithm and you really haven't found a reason for the patient to be coughing. In 10 to 25%, you will not find a cause. And up to 42% of the patients, if you did actually find a cause despite treatment, the patient still reports coughing. So what is there to offer? What can we give our patients? It's obviously, like we said, it's a very debilitating symptom. One thing to note, there are no FDA-approved treatments for chronic idiopathic cough. However, there are some randomized placebo-controlled trials out there that have shown improvement with interventions that target the neuronal hyperresponsiveness. So this is one of the randomized placebo-controlled trials. This was published in the American Journal of Respiratory and Critical Care Medicine in 2006, and it studied low-dose, low-release morphine sulfate 5 milligram twice a day, and it found that it was effective for managing intractable chronic cough, and that it significantly lowered the cough severity and improved quality of life. This is another study that was published in the Lancet in 2012. It's a double-blind placebo-controlled trial, and it looked at gabapentin, which our patient was on by ENT for the refractory chronic cough, and it showed that it was associated with a greater improvement in cough-specific quality of life and reduction in cough severity. And this was another study that was published in BMJ. I thought this was actually very interesting. Again, it's a randomized placebo-controlled trial, and it looked at speech pathology treatments or speech therapy, which is something that we have at Henry Ford, and it involved four different components: education, reduction of laryngeal irritation, cough control techniques, and psychoeducational counseling. And it showed that it was shown to reduce the cough severity and improve the quality of life. So this is, just a summary of the different algorithms that you can go through when you're assessing someone. I got this from, again, the same New England Journal of Medicine article that I used, and it's pretty much sums what we said. But in summary, chronic cough is a common and often a challenging symptom that we usually see in the outpatient setting. It could be the presentation of a, underlying severe pathology such as malignancy. The more common cases are usually due to asthma, GERD, postnasal drip, or a combination of all three. And then the first workup to be obtained is usually a chest X-ray. These are my references, and that's all. I'd like to thank Dr. Abdulla for giving me the case presentation of the patient that we talked about, and also for guiding me in the presentation, and I'm open for questions.